to spot participants. All lines have been muted at the start of the presentation. If you would like to ask a question or otherwise communicate with us, please use the chat button in the upper right corner of the screen. There's a better view of it. And that will open the chat box in the bottom right of your screen. Before you type a message, you need to choose the recipient of the chat. Your choices are host, which would be me, the presenter, who's the person currently showing the slides, or all the panelists or all of the attendees. Most of the time, you will probably want to send your message to all attendees so that everyone can see your question and the right person can address it. If you prefer to ask your question out loud, you can raise your hand, and when we get to the right time in the presentation, we will unmute your line and allow you to ask your question or make your comment then. And this is a closer view of the hand icon. The main thing that you need to know, though, is that in order to unmute you, you have to be logged into your phone correctly. If you connected by computer, then you're automatically logged in correctly. But if you called and did not enter the attendee ID, we aren't able to unmute you when the time comes. If you want to call back so that you can do that, click on the Event Info tab and use the number listed on that screen. You can tell if you're connected correctly if either a computer or a phone icon appears next to your name. If it's blank to the left of your name, you can either just stick with the chat or you can call back. It's your choice. If you're having problems with any of the technology of the webinar, please do feel free to send a chat to me as the host. And with that, I'm happy to hand the platform over to Suzanne.
Great. Thank you so much. My name is Suzanne Cray, and I just want to welcome everyone to today's webinar. On behalf of the Massachusetts Department of Public Health, I just want to thank you for participating and for your willingness to engage in this important work. Using funding from the Centers for Medicare and Medicaid Services, the department has engaged with Apt Associates to support nursing home teams to develop effective QAPI programs across the Commonwealth. Effective QAPI programs can prevent adverse events, promote safety and quality, and reduce risk to residents and caregivers. So we're pleased that you are participating in this collaborative effort, and we hope that today's webinar will provide you and your staff with tools and information needed to foster quality improvement efforts in your nursing home. The Department of Public Health is enthusiastically supporting this work, and we look forward to continuing to work together to improve the quality of care in nursing homes. And again, I just want to thank you for joining us today, and please remember to share this important information with your staff. Thank you so much.
Okay, thanks very much, Suzanne. And let me introduce our speakers for today, and the speakers are pictured on this slide. First is Donna Hurd, and Donna is a master's prepared nurse and a senior associate at Apt, and she has an extensive background, including as a former director of nursing in long-term care facilities in Massachusetts. She's worked in contracts with CMS and ARC, where she's assisted with the development of training materials related to pressure ulcer prevention, falls, unavoidable hospitalizations, and catheter-associated UTIs, and she also led the development of the training materials for team steps in long-term care. Our colleague Rosanna Bertrand is unfortunately not able to join us today, but Rosanna, many of you have met her already as well. She's a gerontologist and associate scientist at Apt, and Dr. Bertrand has over 20 years experience in issues related to older adults and long-term care. For about the past 10 years, her focus has been on conducting nursing home research, and including with site visits through contracts, such as the evaluation of the Quality Indicator Survey and the Special Focus Facility programs. She's also done some great work around standardizing antibiotic use in long-term care settings and using nursing home antibiograms to improve antibiotic prescribing and delivery. Additionally, Rosanna worked with me and others at Apt on the CMS's QAPI contract, or QAPI contract that Apt worked on with CMS, and particularly Rosanna dealt with developing tools to empower residents and families to engage in nursing home QAPI. And Gabby Katz is one of our colleagues on the team, and she's an analyst at APT, and she serves as the AppSpot Initiative Team Data Manager. And through APT's Nursing Home Compare contract, she's helped to research and write recommendations on nursing home satisfaction measure, and has worked with a nursing home in Massachusetts to implement a bundled payment program, and has conducted racial disparity research in nursing homes at Brandeis University. Gabby also worked with the Massachusetts Health Policy Commission researching trends in state long-term care. As I mentioned, I'm Jen Pettis. I'm a nurse researcher and associate at APT, and the project director for the AppSpot initiative team. I'll share with you that I love this project. Being out in the facilities with all of you has been wonderful. We have completed some evaluations of this year's new SPOT participants, and we are on to what I think is the really fun part, which is the technical assistance visits, where we actually come into the nursing home and help all of you to develop a quality improvement program that's really specific, tailored to your something that's important to your facility. So we've worked on everything from bruises of unknown origin to too much noise in the facility, to urinary tract infections and falls prevention, and antipsychotic medications and resident behaviors, and just a whole host of things that are important information or important initiatives to the particular facility. So we have a great process that we think you'll be able to use to apply it to anything within your facility. So we are anxious to get there to work with you. We're finishing up our July visits, in the process of scheduling our August visits. And if you are saying, well, I haven't heard from you yet, but I'm hoping for my visit sooner than later, certainly feel free to reach out to us. We will be visiting all 60 participating nursing homes by the end of October. There's also a lot of activity around the webinars, and Gabby will tell you more about that in just a little bit. So I'd like to ask you guys a couple of questions. The first one is to see how many folks are participating with you. So the question is, how many people, including yourself, are participating in this webinar together? So we'd like you to just take a moment and click in that poll to the right of your screen where it says 1 if it's just you, 2 to 3 if it's you plus 1 or 2 other people. Click C, 4 to 5 if it's you plus 3 or 4 colleagues. And if it's 6 or more folks, including yourself, go ahead and select D. And we'll show you the answers in just a moment. And I did see we had a question in the chat. Someone was asking about the number to call in, so I know if Jean hasn't already addressed that, she'll do that as soon as she's done with the poll. Jean, should I move on, or do the answers pop up for the poll?
It should have popped up, but it does not appear to have.
Okay, well, we'll move on. We'll get the info later, no problem. All righty, I just didn't want to wait if I shouldn't be waiting. So I have one other question for you here before we move on, and that is to find out a little bit about who exactly is joining us today. So we'd like you to check all that apply for this. We'd like to know who's participating. Is there an administrator, a director of nursing, a QAPI coordinator, other department heads, like maybe a social service department head or rehab department head? Are there mid-level managers, like dietary nurse managers or supervisors or rehab managers? And are there frontline staff, like unit nurses, certified nursing assistants, or therapists? And please check all that apply. And you've got just about 15 or so seconds left. And while you're selecting and participating in these polls, I want to mention that we will have a couple of other opportunities for polling. One will be a more traditional polling question where you select one answer, and the other will be a check all that apply. We're also going to ask you at one point in this program to actually chat in and give us some feedback in the chat answers. in the chat box so we can have a bit of a discussion with you guys as we move along.
And also don't forget to choose submit when you're finished.
Great. We have some staff in each and every category, including frontline staff, mid-level managers, each and every category that's represented there. So that's wonderful. And Suzanne encouraged folks to share this program with your staff. You will receive a link. Jean mentioned that earlier. You'll get a link to this program so you are able to share it with your staff. And again, you'll get that relatively quickly. So our objectives are listed here on this slide, and our objectives to the program are that upon completion of the webinar, you'll be able to describe the steps in the root cause analysis process, to explain the types of incidents or events that are appropriate for root cause analysis, to describe who should be on the team to conduct the root cause analysis, and describe the difference between a contributing factor and a root cause. And at this point, I'm going to turn the presentation over to my colleague, Donna, who will begin with the definition of root cause analysis. Take it away, Donna.
Okay. Thanks, Jen. So if we could move to the next slide. Here we go. Root cause analysis is a process that involves a structured team effort to identify underlying causes or factors or the actual reasons behind an event or near miss that resulted in or could result in undesirable outcomes and develop corrective actions. That's a long definition. But root cause analysis provides you with a way to identify breakdowns in processes and systems that contributed to an event and how to prevent future events. So when we talk about processes and systems, we're referring to the ways that you do things. Those are the processes in the nursing home, which is the system. This structured approach is designed to get to the underlying cause of a problem, which leads to identification of effective interventions that can be implemented in order to make improvements. Root cause analysis focuses on systems and processes, not on the performance of individuals. However, it doesn't replace appropriate personnel action in the case of employee misconduct, but it does help you take a wider view. We know that you're all working to improve resident service and quality of care every day, and most of the time you can do that. But we also know that in every system or nursing home, there are challenges and mistakes happen, and sometimes these mistakes can result in injury or harm to a resident. The nursing home is a busy place with many people working in various departments, and everyone has to be actively involved in improving resident safety. The purpose of root cause analysis is to find out what happened, why it happened, and determine what changes need to be made. Often what seems like the obvious reason for why something happened is not the only reason, or even not the real reason that the event occurred. Root cause analysis leads into digging deeper and deeper into the issue to find the reasons behind the reasons. Here's a common issue that we can use as an example of a problem that might be addressed using root cause analysis. This problem is that medications are not delivered to residents in a timely manner. Often medications scheduled for 8 a.m. are not being given until 9:30 or later. So a quick explanation might be that the nurses are not aware that the facility has a policy that requires that nurses administer medications within a 2-hour window, 1 hour before the scheduled time and up to 1 hour after the scheduled time. One possible solution would be to in-service or retrain the nurses on the policy and hope that they do better. However, using root cause analysis might uncover that the nurse, though she's aware of the time frame deadlines, cannot deliver all of the patient's medications in 2 hours. Suppose each unit has 40 patients and each patient has 6 medications, some which require vital signs, or that time be allowed between the medication, like with eye drops or inhalers. One nurse would be handling 40 times 6, or 240 medications over 2 hours, which is 120 minutes. And that allows only 2 minutes per resident, which we know isn't adequate or safe. So what might be a stronger solution? To correct the problem by addressing the root cause of the issue by allowing nurses more time to administer the medications by staggering the scheduled times. maybe staggering the medication schedule time so that the residents on the right side of the hall get their medications at 8 a.m. and on the left side at 9 a.m. So can you see that if we had considered the problem solved by giving the nurse an in-service, that might not have really fixed the problem? Using root cause analysis uncovered additional issues around the MedPass and allowed the team to come up with a better solution. So the goals of root cause analysis are to find out what happened, why it happened, and what changes need to be made to prevent it from happening again. Root cause analysis can lead the team to develop an action plan to prevent an event or issue from happening in the future. So here are the steps for conducting a root cause analysis, which we'll describe briefly here and then cover in more detail later in the program. Step 1 is to identify a problem that needs root cause analysis. Events and issues can come from many sources, and I'll share some examples of those shortly. Step 2 is assemble a team consisting of a leader and a facilitator and team members with personal knowledge of the processes and systems involved in the event. Step 3, construct a timeline to describe what was going on around the time of the event or the issue. Step 4, identify the situations, circumstances, or conditions that increase the likelihood of the event or issue occurring. Step 5, identify root causes. A thorough analysis of the contributing factors leads to identification of underlying process and system issues, or root causes. Step 6, design the fix. The team determines how best to change processes and systems to reduce the likelihood of another similar event. And step 7, measure success. Evaluate the success of your intervention. Okay, so let's look at step 1 in a little more detail. Identifying the problem. Events that may be investigating using root cause analysis can be identified from many sources. For example, incident reports, DPH citations, risk management reports, staff, resident, or family complaints or feedback, staff reports of near misses. High priority should be given to events that resulted in significant resident harm or death, or other events that the facility is required by regulation to investigate. Also consider investigating near misses or close calls that could have resulted in harm to the resident, but did not by luck or timely intervention. The facility should have a process for selecting these potential events or issues that require examination through root cause analysis. The facility should prioritize these events that represent the highest risk to residents or affect the most residents. Also consider factors like the extent to which the events affect the residents' quality of life, the feasibility of implementing an intervention, and the responsiveness to resident and family concerns or needs. Once an event or issue is identified, someone involved in quality assurance and performance improvement, or QAPI, can begin gathering the preliminary information, including the incident report and other documentation from the preliminary investigation. This may include interviews with those involved, including the resident or family members, review of relevant policies and procedures, or examination of equipment. This preliminary information is also useful for deciding which individuals should be invited to serve as members of the team. So here's an example of a real-life event. CNA Mary needed to transport her resident, Mrs. T, to the dining room. She located a wheelchair and brought it to Mrs. T's room. She explained the process to Mrs. T, who was sitting in her lounge chair in her room. She applied the gait belt and assisted the resident to stand and pivot into the wheelchair. When she has Mrs. T seated in the wheelchair, Mary noticed blood on Mrs. T's pant leg and a long, nasty-looking gash on her calf. She called for the nurse manager to come to the room. Nurse manager assessed the wound, called the physician, and the decision was made to transfer the resident to the emergency department for an evaluation. She may need stitches, explained the charge nurse. And she then asked Mary what happened. Mary explained the footrest on the wheelchair that she had grabbed did not fully swivel out of the way for the transfer. Maybe she cut her leg on the footrest. Mary said. Later that afternoon, the resident returned from the hospital with 25 stitches in her leg. The facility reported the incident to their Department of Public Health as a serious injury had occurred to a resident. So next we have a polling question. So we're going to ask you, the team decided that they were going to conduct a root cause analysis on this incident, and they want to identify first what they know. So let's help them by selecting all the facts about the situation that you know. So in this question, we're going to check all the details that we know. So check all that apply. So do we know A, the resident sustained an injury requiring stitches while transferring into a wheelchair? B, the CNA was not careful during the transfer. The injury, C, may have occurred during a transfer to the wheelchair. D, the CNA explained the process of the transfer to the resident. E, the CNA used a gait belt with the transfer. And F, the footrest on the wheelchair did not fully swivel out of the way for the transfer. So looking at the poll, check all that apply of those details. What do we know? And don't forget to hit the submit button after you've made your selections. You can pick more than one. I'll give you a few minutes if our results come up. Oh, there we go. Okay. Very good. So let's talk about these. So we know that the resident sustained an injury requiring stitches. However, we don't know, without more investigation, that it definitely happened during the transfer. We need to find out what happened by asking more questions. So A would be something we're not really sure of at this point. B, we don't know whether or not the CNA was careful. All too often, assumptions are made that staff are not careful, and they're blamed instead of addressing the true cause of the injury. So B is definitely one of the things we don't know. C is correct. We know that the injury may have happened during the transfer. D and E are also correct. We know that the CNA explained the process prior to transferring the resident and used a gait belt. And F is also correct. We know that the footrest did not swivel fully. So here's an opportunity to chat. Based on our example, what else would we want to know? So please use the chat feature on the webinar to type in other things that we might want to find out about. Jean, do you think we need to remind folks how to use the chat function? The chat box is up in the ribbon at the top on the right. Let's see. See if we can get any folks to write in a chat. So you enter your chat message, and then you have to say send.
We do have a few chats. We have, was the nurse's aide a new employee? And were there any witnesses other than the CNA? And the last time care was performed prior to transfer? We're getting lots of answers.
That's
what
great.
What was the resident doing prior to the finding? Any previous existing issues?
All good information to get. Definitely. Very good. So let's kind of group these. So we might want to know more about the wheelchair. What was the condition of the wheelchair? So yeah, some people have asked about the wheelchair. We'd want to know, is that Mary's wheelchair, or was it someone else's? Or was it a transport chair? We want to know, was it marked for repair, since it didn't seem to be working correctly? And was there some kind of a preventive maintenance program to examine the equipment for needed repair or removal from service? So We had some questions about, would the wheels come off, or did they just swivel? That's a good question. Let's go on. Let's ask, what else do we know about this nurse assistant? So do we know if she's experienced or not? Is she a new employee? Was she familiar with this resident in this assignment? Could she have been behind in her assignment and in a rush to catch up? Well, we don't know how well. Let's talk about this resident. What else do we know about the resident? So somebody mentioned the order to transfer. What was her transferability? When was the last time her skin was checked? Yep. What was the bin? And was she cooperative? Did she follow directions? Did she have a diagnosis that would have made her skin more fragile or likely to bruise? These are all good. And was her skin intact before the transfer? That's right. So we know that the nurse did confirm with the CNA that she saw her skin while she was helping her put on her shoes prior to the transfer. So she noticed there was no problem before that, so it was definitely intact prior to the transfer. So they're confident that the injury occurred during the transfer. And on further investigation, they did see blood on the footrest. Yep, so somebody asked was there blood on the wheelchair. This is great. Thank you all for chatting with us. So let's go on to step 2. Step 2, we have to assemble the team. So we first need to designate a leader who will facilitate the root cause analysis. The leader is responsible for assembling and managing the team, guiding the analysis, documenting the findings, and reporting to the appropriate people. The number of team members depends on the size and scope of the investigation. Individuals selected to serve as team members should be familiar with the processes and the systems associated with the event. People who have personal knowledge of what happened should be included as team members, or at least given an opportunity to contribute to the investigation through interviews. Team members should be selected for their ability to discuss and review what happened during an event in an objective and unbiased manner. In some situations, staff members who are personally involved are the best people to join the team. But in other situations, it's better to have those who are not personally involved if they can't be objective. We suggest that you keep the number of management or supervisory people involved to a minimum. Some staff may be intimidated or not completely candid if their direct supervisor is in the room. The facilitator should explain that all members should be free to discuss the situation honestly. And lastly, make it clear that the root cause analysis process is confidential. This may help people feel safe when discussing factors that led to the adverse event. So now that the event has been identified and the team members assembled, it's time for the first meeting. So the leader will orient the team to the root cause analysis process so that all participants have an understanding of the process. Explain the role of the leader and the team members, assign someone to record notes, decide on future dates for meetings and times if future meetings are indicated, and then review the rules of behavior and expectations. For instance, as you begin the meeting, you might want to ask the team to please be respectful of everyone's input and consider fellow attendees by refraining from sidebar conversations and keeping their body language and comments respectful of others. So at this point, I'm going to turn the presentation back to Jen, who's going to continue with step 3.
Okay, great. Thanks, Donna. In step 3, you'll construct a timeline. At the first meeting of the team, preliminary information gathered in step 1 is shared with the group, and any additional details are obtained from team members. All of this information is used to create a timeline, a sequence of events leading up to the harmful event. In the timeline, you'll outline the event, beginning with the first known fact and progressing through the final known fact. The timeline should describe only the facts, not what caused the facts to happen. Causal factors are added later. So here's a timeline for the incident described earlier when the resident sustained a deep laceration during a transfer from her stationary chair to the wheelchair. First, Mary, the CNA, went into the room with the wheelchair. She explained the process to Mrs. T and placed a gait belt on the resident. Mary helped Mrs. T to stand in her transfer from her lounge chair to the wheelchair. After Mrs. T was in the wheelchair, Mary saw the blood on the resident's leg and noted the laceration or skin tear. And Mary notified the charge nurse. Mrs. T was transferred to the emergency department for evaluation. And then she returned later on with 25 stitches in her calf when she returned from the ED. So you'll review the timeline to make sure that it tells the story of the incident. If the timeline does not adequately tell the story, the scope of the timeline can be extended further back in time or expanded to include what happened after the event. Ask yourself and your teammates, does each step logically flow from the one preceding it? If not, maybe one or more steps have been left out. You would want to add those steps to the timeline. Lastly, ask yourself if each step is pertinent to the incident under investigation. The answer may be yes, no, or not sure. Include the yeses and the not sures steps in the timeline, but not the no's. In step 4, we're ready to dig deeper into what happened to discover why it happened. The team looks at each step of the timeline and asks, what was going on at this point in time that increased the likelihood the event would occur? These are the contributing factors, situations, circumstances, or conditions that collectively increase the likelihood of an incident. By itself, a contributing factor may not have caused the incident, but when several contributing factors occur at the same time, the probability of an incident will occur increases. So look at each step of the timeline while the group brainstorms for possible contributing factors. Ask what was going on at each step that might have increased the likelihood that the event would occur. Try to determine if there were recommended practices that were not followed or any workarounds that might have occurred or staffing issues that might have contributed to the event. At this stage, it's important to get the perspective of the people personally involved in the event. Excuse me, these may be the only individuals aware of the actual circumstance affecting what happened. For instance, the CNA in our example who used the wheelchair that was not working correctly, remember the footrests would not fold back completely, she may have been pressured by her nurse manager to complete her assignment on time. Team members not personally involved in the event might not be aware of this contributing factor. On the next 2 slides, we'll look at some contributing factors that may have been identified for a couple of steps in our timeline. Here are some potential contributing factors to the first step in the timeline when Mary went into the resident's room with the wheelchair. She had had a hard time finding a wheelchair and found the one that she used buried in a unit closet. So either Mrs. T doesn't have her own wheelchair or it was missing, but it seems like she may be using either someone else's chair or a chair taken out of service or a transport chair of some kind. Maintenance had tagged the wheelchair to not be used, but it did not remove it from the unit. The CNA did not notice that the wheelchair was tagged. A tag was later found on the floor of the closet during the investigation, so it seems like maybe it was tagged and the tag fell off the chair. Maintenance is responsible for wheelchair repairs, but they don't have a system to ensure that chairs are regularly checked. And there's no consistent process to notify the maintenance department that a piece of equipment needs repair. Sometimes nursing calls them directly. Sometimes issues are reported to the DON or to the administrator, who then report it to maintenance. And here are some potential contributing factors to the 4th and 5th steps in our timeline. Mary was helping the resident stand and transfer from the lounge chair to a wheelchair, and she saw blood on Mrs. T's leg and noted a skin tear. The resident was late for a special activity she was looking forward to. The CNA looked around for someone to help, but everyone was busy or off the floor on break. She used a wheelchair even though she noticed that the footrest would not swing back completely, and she had been reprimanded the previous week for not completing her assignment on time. Consider these 4 contributing factors. The CNA involved was definitely needed to uncover most, if not all of these. She certainly would have been the person to know those last 3 that I mentioned about looking around for someone, using that wheelchair even though she noticed the footrest wouldn't swing, and having been reprimanded the week before. So all incidents have a direct cause. The resident's leg was injured on the wheelchair during the transfer in our example. That's the direct cause. It's the occurrence or condition that produced the incident. However, the direct cause is not the root cause. Root causes are underlying faulty process or system issues that lead to a harmful or potentially harmful event, and oftentimes there are several root causes. Contributing factors are not root causes. The team needs to examine the contributing factors to find root causes, and this can be done by digging deeper. So the good news is that there are tools to help identify root causes, including the 5 whys tool and the fishbone diagram. And we're going to discuss each of these in a little more detail. And I should mention as well, when you have your in-person spot visit, you'll be introduced to these in much more detail when we actually work together with your teams. So the 5 whys tool is a simple problem-solving technique that helps to get to the root cause of a problem quickly. It involves looking at a problem and asking why or what caused this problem. Typically, the answer to the first why should prompt another why, and the answer to the second why will prompt another, and so on. The team asks if the most recent issue mentioned or most recent response was corrected, would this problem have been likely to occur? If the answer is yes, then that response is a contributing factor and not a root cause. The team keeps asking why until there's agreement that a root cause has been identified. So it's simple and easy to learn, and let's consider a contributing factor from our example. In our example, the CNA looked around for someone to help her, but everyone was off the floor or busy. The team would ask, why was everyone off the floor? And the answer, well, because the CNAs were not assigned breaks, so they took their breaks when it was convenient for them. And the next question would be, why were the CNAs not assigned breaks? And the answer to that was, well, because the charge nurse was covering for the nurse manager who was out sick, and she forgot that she was supposed to assign breaks. Why didn't the covering nurse remember that she should assign breaks? Because the nurse is rarely in charge, generally only once every couple of months, and finds it hard to remember each thing that she needs to do as a charge nurse. When she and the nurse manager discussed this upon the nurse manager's return, they developed a checklist of required tasks for nurses filling in as charge nurses to use as a guide. So does this remedy that this quality improvement kind of process that they're putting in place now, they're putting this checklist in place, does that really address the laceration or the wheelchair problem? No. But what does it do? It can help prevent future safety concerns, because there's a process at least to take out that piece of making sure that there's enough coverage on the floor. So you're absolutely, even though it's not the only thing that needs to happen in response to this event, it is one of the things that can happen in response to it in order to help keep residents safe in the future. So here's an example of the 5 whys. We start with Mrs. T has a laceration on her leg, and then we ask why she has that laceration. The answer is because she hit her leg on the wheelchair footrest. Well, why did she do that? Because the footrest didn't fold back out of the way all the way. So then we simply ask, well, why didn't the footrest fold back all the way? And it was because it was stuck or it didn't stay back all the way when the nursing assistant pushed it back. Well, why is that? Well, because the chair is old or damaged. We know that it was tagged for repair, but somehow got put in the closet there. So why is it damaged? Well, there's not a set process or schedule for ensuring wheelchair maintenance or for removing damaged equipment from the unit. So our performance improvement project would include an action or actions to address that final issue. And we need a set process to ensure that wheelchairs are maintained, and we also need a process that makes sure that when things are broken that we get them off the unit. So your residents, I always think of those stationary chairs when they've been dragged around the floor enough and they start to pull apart, and somebody says chair broken, but the chair stays on the unit, and the resident who's wandering around the unit and exhausted and needs a place to sit sits down in the broken chair and then is injured. So a process to not just make a sign for those things so that we can see it, but to get it out of the reach of the residents and staff altogether. Well, the fishbone diagram is another tool you can use, and it is a cause and effect diagram, and it can help in brainstorming to identify possible causes of a problem and in sorting ideas into useful categories. The more structured approach than some other tools available for brainstorming causes of a problem, and the problem is displayed on the head or mouth of the fish, and possible contributing factors are listed on the bones of the various cause categories. The fishbone diagram can be helpful in identifying possible causes for a problem that might not otherwise be considered by directing the team to look at the categories and think of alternative causes. It may be used in conjunction with the 5 whys to help keep the team asking why until the actual root cause is found. So here's what a fishbone diagram might look like for our example. You can see equipment, process, people, management, environment, and materials are those categories that we're looking at. So some of the examples there in people, the CNA is rushing to get her work done. She's trying to get that resident to an activity. She used a wheelchair even though it was damaged. But process, there's no consistent process for notifying maintenance or of regularly checking the wheelchairs. This wheelchair that had been tagged wasn't removed from the unit. That tag was found on the floor. The CNAs weren't assigned breaks, one of the management issues. So this tool can really be helpful to say, why did it happen? And just say, well, did we think about anything going on in that environment or anything that was materials related that might have led to this problem? So it's a great tool. And at this point, I'm going to turn the program over to my colleague, Gabby, who's going to take you through steps 6 and 7.
Thanks, Jen. In step 6, the team evaluates each root cause to determine how best to reduce it or prevent it from triggering another harmful event. The key is to choose actions that address each root cause. At least one corrective action should be developed to reduce or eliminate each root cause. Interventions can be ranked according to their strength, either strong, intermediate, or weak. Strong actions focus on system changes and don't rely on an individual's memory. Weak actions rely on memory or retraining. Intermediate actions fall somewhere in the middle. Teams should aim for corrective actions that are strong or intermediate. So on this slide, we provide examples of stronger, intermediate, and weaker actions. Stronger actions remove the dependence on the human to get it right. They are physical and permanent rather than procedural and temporary. Examples include architectural physical plant changes, new devices with usability testing before purchasing, simplifying the process, and removing unnecessary steps. And this one is important in particular. Simply changing a policy is considered a weak step. However, when a policy is simplified and unnecessary steps in it are removed, opportunities for errors are reduced and more likely to be achievable by the staff. Another example of a strong change is standardizing equipment or process. So in nursing homes, we have a lot more intermediate examples than strong ones, but one that I can think of for an architectural or physical change was, in the past, they created needles to eliminate the need of recapping them, and thus that decreased the potential for needle stick injuries. Another example is when they packaged all of the supplies needed for a dressing change or catheter insertion, which eliminated the need for unnecessary steps. Intermediate actions reduce the reliance on the human to get it right, but do not fully control for human error. Examples include checklist or cognitive aids, eliminating look and sound alikes, read back, enhanced documentation and communication, and redundancy. Examples in the nursing home setting might be to ensure that every unit provides a report for CNAs at the beginning of the shift, or having a sign to show staff and visitors that medication nurses should not be interrupted during MedPass. Weaker actions support and clarify the process, but rely solely on the human. These actions do not necessarily prevent the event or cause from occurring. Examples include double checks, warning and labels, new memorandums, training, and additional study and analysis. Examples in the nursing home would include providing an in-service to the medication nurse that we used as an example earlier in the presentation. The med nurse was failing to get the medications delivered to the residents on time. An in-service could have been provided to make sure that she knew the requirement, but would not have solved her problem of too many medications all scheduled for delivery at the same time. So now let's do a quick poll. So based on our conversation of strong and weak corrective actions, we have a poll. Which corrective action do you think, when implemented alone, is unlikely to result in a lasting change? So which one do you think would be a weak corrective action? So I'll just give everyone a minute to choose. The actions are A, development of a checklist, B, simplifying the process, C, reminding staff of a step, and D, standardizing equipment. So you choose which one you think is the least likely to result in a lasting change, and remember to hit submit at the bottom. Just give everyone a few more seconds. Okay, let's see if the answers pop up. Oh, it looks like everyone got it right. The correct answer is C, providing staff training. Providing only staff training as an intervention to address an issue is based on two assumptions: lack of knowledge that contributed to the event, and if a person is educated or trained, the mistake won't happen again. These two assumptions are generally not true, nor do they address the root cause of an issue. When designing corrective actions, clearly state what is to be done, by whom, and when. Satisfactory implementation of the corrective actions will be monitored, so it is important to have clearly defined plans. Because the feasibility and costs associated with corrective actions must also be considered, it is helpful to include facility management in the corrective action discussion if they are not already members of the team. If a particular action cannot be accomplished due to current constraints, for example, a lack of resources, the team should look for other ways of changing the process to prevent a similar event from occurring in the future. Doing nothing should never be an option. And let's move on to the final step, step 7. So once you've chosen your corrective actions, you'll want a system in place to measure the success of them. What you measure should provide answers to these 3 questions. Did the recommended corrective actions actually get done? Are people complying with the recommended changes? Have the changes made a difference? In our example, we'd want to know if faulty equipment is now removed from the unit by maintenance immediately upon notification. We'd also want to know if there's a consistent process in place for notifying maintenance that a piece of equipment needs repair. Also, sufficient wheelchairs are available for transporting residents who require them. And finally, nurses' aid assignments include break times that do not leave the floor with inadequate coverage. So yesterday I emailed everyone who had registered for the webinar a copy of the slides for today and also this handout. It's a root cause analysis performance improvement project, or PIP template. This handout can be used to document the root cause analysis process, including follow-up actions and measures. So if you have the handout with you, if you want to just take a look, you'll see on the first page it describes, you can write in the date started of your PIP project, which team members you would like involved. On the second page, you can fill in root causes of a particular problem, and you'll list them out in corrective actions. You'll also describe who's responsible for those corrective actions, and you'll also create a deadline and write out measure of successes, and lastly, a reporting schedule for the people responsible for reviewing the results. So if anyone did not receive this worksheet, when I send out the link for the recording of this webinar, I'll be sure to send out the worksheet again so you can have it. So just before we get to the Q&A, I wanted to briefly cover our past webinars and future webinars so you have logistical information. So if you haven't seen the previous webinar to this, it was called Overview of Quality Assurance and Performance Improvement. I can also send out a link for the recording of that webinar, and we encourage that you share that webinar with all levels of staff on your team. Our future webinars after today will be on September 28th from 2 to 3 p.m. We'll have Improving Communication. And then on November 16th from 2 to 3 p.m. we'll cover Engaging Residents and Families in QAPI. And both of these webinars, the registration links are already available, and I'll be sure to send you that in an email as well. So one more thing before we move to Q&A, we'd like to ask that you all complete the evaluation of today's webinar. So after you exit out of this webinar, a new tab in your browser will pop up with a few questions, and if you don't mind just filling those out, we really appreciate it. Your input helps us tailor our future webinars. So with that, we'll move to Q&A, and I think we'll let Jean help with this.
Okay, so as a reminder, please use the chat feature in the top right corner of the screen to enter a chat. Also, if you have, if you would like to raise your hand, you can do so as well, and we can unmute you. I do have one request that's come in, which is to provide blanks of the fishbone chart. That it's very valuable and would be nice to have that.
So Jean, we can do that. We can provide a template for the fishbone.
Excellent. Thank you, Donna.
Additionally, there is a template of it in the packets that you'll receive as you're scheduling your site visits for us.
Okay, one other question that we received is why is root cause more effective than our usual investigation tool we use for incident reports?
Oh, it's Jen. I'll take that question, Jean. I think the first thing to stress is that we don't really know what your specific investigative process is. However, very often what we see is more traditional investigative methods rely more on chain of command or management to investigate issues and really take kind of a more linear approach, focusing on finding a single error made by one person. Very often the person at fault rather than the underlying causes is sought in that kind of method. And these really often lead to punishing people or re-educating staff or reminding staff, where root cause is really different in that it's a team approach that's used, and it's based on recognition that issues and adverse events usually have a number of factors that are causing them. It's really very rarely that it's an error. It's almost never that it's an error, an issue that happened on purpose from an individual. And really with root cause analysis, the focus is to learn from the error. I mean, you can see from our example, if all we did was re-educate the CNA about a safe transfer, we wouldn't have addressed really those underlying causes of the wheelchair isn't safe, it wasn't taken off the unit when it should have been. There were lots of other issues that really were the root causes of that the team can then come together and fix as a team. Thanks for the question. That's a great question.
Thank you. Another question we got in is, you mentioned direct cause and root cause. Can you tell me the difference between those two again?
Jean, this is Donna. I'll try to answer that one. So a direct cause is the obvious or like the immediate cause of an issue. So, for example, a staff not wearing gown, gloves, and mask when they should have been. So the direct cause is that you didn't put them on. But the root cause could have been the situation that allowed that direct cause to happen. So, for example, if the staff member had to urgently enter a room and there was no personal protective equipment in the cabinet, outside the door, why was that? So the cause of that was maybe that the previous shift didn't stock the cabinet. The reason that they didn't stock the cabinet is probably the root cause for the staff member who didn't wear it when he or she entered the room. So simply re-educating that staff member on the need to utilize professional protective equipment would not have solved the issue. Had to look further back to find out why it wasn't there.
Jane, did we have any other questions that came in?
Not currently.
Okay, well, I want to invite everyone to, if you do have questions, we have a couple of minutes left, please enter them in the chat or raise your hand and we can unmute you. I want to thank you all for participating, especially for so robustly participating in the chat. That was great, and participating in the polls and answering the questions that you did. I also want to thank those of you who have already welcomed us into your facilities to work with your teams on the performance improvement. And I want to encourage you to reach out to us at the email, the nursing home quality email that the invitations and information comes from. The SPOT team is here as a resource to all of you. If you're looking for particular quality resources or things, we very often can put our hands on them and get those out to you pretty efficiently. As I mentioned before, if you're in the position that you've got a quality issue that you're really hoping to get started on sooner rather than later and would like to have your SPOT visit sooner rather than maybe you're currently on the books for September or October. You wouldn't know that yet. We would know that. We've only contacted the folks that are having the visits in August, but reach out to us. And Gabby just sent a chat there. If you have any concerns or questions, there's our email. It's nursinghomeqi@mass.state.ma.us. We look forward to continuing to work with you all and to having you participate in our webinar that will come up in September when kids are back to school and summer's over already. Yikes, that's only 2 months away. So again, thanks all so much for joining us. And please do fill out those evaluations. We appreciate your feedback, and we look forward to working with you all further. Thanks so much.